Thank you to GIE for the opportunity to talk about our paper hybrid resection versus conventional hot snare resection for laterally spreading lesions of the papilla. By way of background, laterally spreading lesions of the papilla comprise about 30% of all papillary adenomas, and certainly a large proportion of the patients that are referred to our centre due to the complexity of the resection that's required. They certainly can be treated effectively and safely by endoscopic means with EMR and then papillectomy. The thinking behind this paper was to address the issue of mainly post-procedural bleeding after hot snare resection. We previously published in GIE, Klein et al., I think from about 2016, that hot snare resection for lesions larger than 3 centimetre in the duodenum carries a risk of 25% of bleeding. And as many of you would know, this bleeding can be life-threatening and very brisk due to the vascular anatomy of the duodenum, where the superior and where the celiac and superior mesenteric plexus meet at the interface between the fore and mid-gut. So richly vascular network, and of course these vessels are injured during the endoscopic resection, and so they may bleed. So you may also be aware of two separate studies that we published subsequently, Sidhu et al., looking at the role of thermal ablation of the margin to prevent post-EMR recurrence, and then subsequently Wang et al. Earlier this year looking at the role of cold snare resection to mitigate the risk of delayed bleeding. These studies were all applied to duodenal adenomas, which of course are relatively uncommon but more frequent than papillary adenomas, and definitely more frequent than laterally spreading papillary adenomas. So based on all of that thinking, we thought that a hybrid resection model where we did cold snare resection of the lateral components and then hot snare resection of the papilla might mitigate the risk of delayed bleeding, but have equivalent risk of recurrence and so forth. Although we had previously shown with cold snare resection the risk of recurrence was about 20%, whereas with hot snare resection and margin thermal ablation in the duodenum, it was only 2%. And those two studies were groups of separate 50 to 60 patients in each arm, and they were compared in sequential studies to the original Klein paper, which was about 150 patients. So that's the background to all of this. So what did we find? Well, of course, the technique is relatively simple to do, although there are some tricks with cold snare resection over the elevator. You need to use a stiff, firm wire, a dedicated cold snare. You need to open it out of view. So you have to have the elevator open, you pass it down, it's out of view, you open it. That way it opens fully, and then you can proceed with cold snare resection. If you open it in view, it won't deploy fully, and you won't be able to use it for cold snare resection. So we, in 20 consecutive patients, we did cold snare resection of the laterally spreading components and then hot snare resection of the papillary component. Procedure was safe, and we were hoping that it would reduce delayed and immediate intraprocedural bleeding, but in fact it did not. There was no significant difference between the established cohort of more than 100 cases of conventional maybe it was only 80 cases for papillectomy for laterally spreading papillary lesions against this new cohort of cold snare resection with hot snare resection of the papilla. Pancreatitis rates were the same, they're both very low. But so it didn't stop bleeding. Bleeding was actually arithmetically increased, but statistically not significant. But what it did do, it increased recurrence. So with cold snare resection, recurrence occurred in 40% of cases, and it took a median of 4 treatments to treat the recurrence, whereas treating recurrence after conventional resection only takes a median of 1 treatment. So recurrence occurs, it's often multifocal, and it's difficult to treat. So this was a pilot study in the hope that we could then mount a multi-center randomized controlled trial, but the evidence from this study involving 20 lesions, median size 30 millimeters, showed that that hybrid resection with cold snare resection of the lateral component, the laterally spreading component with en bloc papillectomy does not reduce the risk of bleeding, and nor does it prevent recurrence. In fact, it increases recurrence, which is very problematic to manage. And I personally think that at least as far as we practice these techniques at present, this concept can now be safely put to bed, and we should continue with hot snare resection for laterally spreading papillary adenomas. We also need to think about incorporating margin thermal ablation, which could also include the deep aspect of the bile duct, but also the lateral margins of the papillary resection, and that should be the subject of further research. So thank you for watching this video. I hope you found it enjoyable, and please do reach out to me directly if you have any questions or queries. We're always very pleased to take questions about our research or other aspects of endoscopic resection in the GI tract. For now, it's Michael Bourke from Westmead Hospital in Sydney signing off.